Great. I think we're started. Thank you very much. My name is Rakesh Arora. I'm a cardiac surgeon intensivist in the University of Manitoba in Winnipeg. I'm very happy to open this session where the co-moderators Sanjay Asupa, Marjan Jahangiri, and Rakesh Uppal. The first talk will be by Sandeep Singh, will be introduced formally in just a moment. This session will be 5 minutes talks followed by 3 minutes of questions and answers to be done on Slido, and we'll do our best to get all the questions as we go forward. Sanjay?
I can't see the slide.
Okay, perhaps I'll start with the first one then.
We start. Thank you.
Yeah, very good. Sandeep Singh will present on should we treat preoperative asymptomatic bacteria, a meta-analysis, and critical appraisal. Can we play the video, please?
Hello, everyone. My name is Ahmed Hussain, and today I'll be presenting a meta-analysis alongside one of my co-authors, Sandeep Singh, on asymptomatic bacteria in cardiac surgical patients. We'd like to acknowledge the help of Cecilia Schwartzman, who's one of the BSUH clinical librarians who helped us perform the literature search. Asymptomatic bacteria, as defined by the Infectious Disease Society of America, is common. The exact prevalence in preoperative cardiac surgical patients is estimated to be between 1 and 10%. It's more common in patients with long-term indwelling catheters, diabetes, elderly patients, and those with hypertension, and these are the sorts of cohorts of patients that we see in cardiac surgery. However, there's little evidence about the impact of asymptomatic bacteria, or ASB, in surgical site infections, or SSI, following cardiac surgery, and practice varies from clinician to clinician, the main concern being prosthetic valve endocarditis. So, we aim to evaluate the benefit of treating ASB prior to cardiac surgery to prevent SSIs. This is an outline of our literature search and the search terms we used. We found 7 papers. One was excluded because it was a meta-analysis published as letter to the editor, and one was excluded because of a lack of focus on ASB. Our primary endpoint was the incidence of SSI in those with treated asymptomatic bacteria and those not treated. This is shown in the top forest plot. The results show no statistically significant difference between the rate of post-op SSI infection in those treated and those untreated, although the confidence intervals are wide due to the small sample size and the overall trend favors no treatment. One Iranian study compared the incidence of SSI in those with normal urine cultures and those with bacteria. When included in the meta-analysis, as shown in the bottom forest plots, the result did not change. There was still no statistically significant difference in the SSI rate, and the overall results still favored not treating ASB. Importantly, only 2 patients from Salazar's cohort reported SSI cultures matching the urine cultures. I'm now going to hand over to Sandeep.
Thank you, Ahmed. As you can appreciate, valve surgery and prosthetic valve endocarditis is particularly important. No valve-specific data was reported in any of the studies. We contacted the authors of the papers and received only one reply. Dr. Cortez informed us in his cohort of 33 patients, 15 had valve surgery. 2 out of 3 of these patients that were treated for ASB developed SSI. This parallels the meta-analysis favoring no treatment, as explained by Ahmed. However, the numbers are too small for us to draw any conclusions from. Here is a brief table. It regards the biases that we saw trending throughout the papers. The biases were present due to difference in clinician review of SSIs with no standardized approach. Surgical experience between the arms were not disclosed. One paper had a loss of follow-up, unevening the arms of the study. In addition, most papers attempted to ensure risk adjustment through either multivariate assessment or log regression, although they had varied baseline characteristics. Here are key factors outlined that explain the biases. Particularly, there was poor recording of surgeons' experience and also the duration of catheter. Surprisingly, Euroscore was not often standardized or mentioned. Some of these factors could indicate, for example, a weaker physiological reserve to fight asymptomatic infections. In addition, recent antibiotic use and CRPs were not often disclosed. One important consideration that's not displayed here and wasn't mentioned in any paper, except Salazar's, was whether ASB was sensitive to the prophylaxis given to them preoperatively, hence giving rise to some performance bias. Concluding this, The trend points towards not treating ASB. It's been paralleled by orthopedic and vascular studies and the Infection Disease of America. Although the data that we collected from a mixture of cardiac surgeries, valve surgery was included in 4 out of 5 of these papers. Nonetheless, unless we get concrete valve-specific data either through a meta-analysis or a randomized controlled trial, treatment going forward will be due to clinician's choice. We would like to carry out a meta-analysis once we receive the reply from all the authors. Thank you very much for listening. This is the end of our presentation.
Thank you very much.
For we're two presenters. Thank you, very well presented. With regards to the asymptomatic bacteria treatment groups, where's there any difference in terms of post-operative surgical site infections or pneumonias with multiple drug-resistant bugs that you found out in those treated with antibiotics?
So a lot of the data didn't actually describe whether there were any resistant bugs in the post-operative phase. What they were doing in this study was just matching whether the pre-op cultures matched the post-op cultures. In terms of pneumonia, one study actually found an increase in 30 patients that were in the asymptomatic treated group to have post-operative pneumonia, but this was also the same in the untreated group. So there was actually no difference between the two arms. Okay.
Great, thank you. Some questions coming in from Slido, Sanjay here. One is the breakdown of terms from Anonymous. Sorry, a breakdown of terms in terms of cardiac surgeries overall. Was there any particular preponderance of one surgery or another?
Sure. So there was roughly around 1,000 cabbages that were seen in all of the studies, and this was mainly from 3 studies because they disclosed which operations they were doing. The other 2 didn't. So there was about 1,000 cabbages, 900 valve replacements, and I think there was around 100 to 120 thoracic aortic surgeries.
Okay, perfect. Another one here from Anonymous. Are there any cohorts of patients you would still treat for ASB despite the non-favorable trend?
So according to the Infectious Disease Society of America, they recommend treating pregnant women. And that's because ASB is prevalent in about 4 to 7% of pregnant women, and the progression to acute pyelonephritis is about 30% without any sort of treatment. With effective treatment, that does drop to about 1% to 4% in pregnant women, according to the IDSA. So they would be the exception to the rule.
Okay. One more, we have time for one more quick one here. Was there any incidence of ASB seen in pre-op cardiac surgery patients in your data set? And was there any link to post-operative endocarditis?
Okay, do you want to take this one, Sandeep?
Sure. I mean, from all the data we got from all the patients, which was roughly around 1,600 cardiac patients, only 2 had endocarditis, and they were both in the treated and untreated asymptomatic bacteria group. What all this meta-analysis highlights as us in a surgical view is looking anecdotally, there's no real need to treat it. But from a research perspective, we need a randomized controlled trial or a meta-analysis on just valve-specific data.
Perfect. There are some more questions in Slido, so I'll ask both the presenters to perhaps type your responses in the app to the ones that we weren't able to get to. And I'll turn it to our co-moderator, Sanjay, to introduce the next speaker.
Right. This next speaker is Jalal bin Saeed, and he's going to present enhanced recovery after surgery in coronary artery bypass graft patients, outcomes of DOSA patients. You're on, Jalal.
Thank you very much for the opportunity to share our experience implementing the enhanced recovery after surgery recommendation in coronary artery bypass graft patients in our unit in Liverpool Heart and Chest Hospital. I have no conflict of interest to disclose. There has been a growing interest since the 1990s in implementing evidence-based practice to enhance and improve perioperative care, which laid the foundation to establish the Enhanced Recovery After Surgery Study Group back in 2005 and the ERAS Society back in 2010. Different surgical disciplines adopted this recommendation and issued their own recommendation, including cardiac surgery guidelines back in 2019. These recommendations cover the 3 phases, the pre-operative, perioperative, and post-operative phase, to improve outcomes in this group of patients. And we can notice that this recommendation is supported with a strong level of evidence. So the objective of our study was to evaluate the compliance with ERAS recommendation in coronary surgery patients, identify domains of least compliance, and see the outcome, evaluate the outcome in off-pump and impaired LV group. So between August 18 and 19, we identified 816 patients underwent coronary surgery. We excluded urgent emergency CABG as well as patients coming from out of the region, as that can have a bias when it's come to the post-operative stay if it's a transport related delay. So we limited our study to the day of surgery admission group, and we looked at the compliance with the recommendation, and the outcome was the length of ITU and post-operative stay. 144 patients were identified. Majority, they are male patients, 90% of the cases, average age of 66 and BMI of 27. Left ventricle was moderate to poor in a quarter of the patients, and off-pump was performed in 55% of the cases. Overall, the compliance with the perioperative protocol and the ERAS recommendation achieved 80% in all of the cases, which has been recommended in the different literature and the experience from general surgery side of thing. However, we noticed that the lowest adherence we had is with the rigid fixation of the sternum in the high-risk patients, including high BMI and COPD and steroid users. As well as a good goal-directed fluid therapy and extubating the patient within 6 hours of ITU admission. We can notice that the goal-directed fluid therapy is a class 1 recommendation, extubation is class 2A, and rigid fixation is class 2A with a randomized evidence. And when we look at this chart, we can notice that different surgical discipline involving osteotomies have moved to the rigid fixation at early stage, and cardiac surgery, we're still behind, relying mainly on the wire cerclage for the sternal closure. When it's come to the outcome, overall ITU stay is 2.8 and post-operative stay is 8.5. When we compared the ERAS group with more than 90% compliance and less than 90%, we noticed there is a tendency for a better outcome with a short post-operative stay. There's no difference in the off-pump and on-pump group. However, when we looked at the good and the moderate and poor LV function, we noticed that the impaired LV group benefited the least from implementing this recommendation. To conclude, enhanced recovery recommendation in cardiac surgery can play an important role in optimizing outcome and minimize complication and cost. Off-pump and on-pump patients benefit equally from implementing these protocols, and impaired LV function, it is counted as a limiting factors for the enhanced recovery strategy. Thank you.
Excellent presentation, Jalal. Are there any questions, Rakesh?
There are one question that's come in so far. We have one here. Sorry, it wasn't clear. This is from Anonymous. But was the effect of ERAS compliance in the LV impaired group? I think you demonstrated at the end in your conclusion slide there, but perhaps you could just restate it again for us there. Have we got our presenter, Jalal? Okay. We may be having some technical issues with Jalal joining. I believe he said that there was a reduction in overall compliance with LV low EF, if I recall his talk correctly.
Yes.
Sanjay, was that? Yeah, great. Okay. Perhaps if there's no other questions coming from Slido at the moment, and Jalal is not able to join us, we can perhaps move to our next speaker.
Yeah, the next speaker is Alina Budakan, and she's presenting Fit for Surgery, repurposing an app-based personalized rehabilitation program to help patients prepare and recover from major cardiac surgery. You're on, Alina.
Good afternoon, everyone. My name is Alina Budakan, and my talk is on repurposing an app-based personalized rehabilitation program to help patients prepare and recover from major cardiac surgery. The reported incidence of pulmonary complications following cardiac surgery ranges from 20 to 95%, with significant patient and cost implications. One modifiable risk factor that could be used to reduce the rate of post-operative pulmonary complications is physical activity. In the UK, patients benefit either from hospital-based or home-based cardiac rehabilitation after a cardiac event or procedure, but the uptake is poor in the region of 50%. This is very likely to reduce even more as a result of the COVID-19 pandemic, hence there is a need to develop a bespoke intervention that can deliver cardiac rehabilitation in a flexible and personalized way. Our previous experience showed that a healthcare app of Fit surgery can deliver rehabilitation before and after lung surgery from the comfort of one's home. In figure 1, you can see a screenshot of the Fit for Surgery app, showing that the patients can build their own program over time and they can tailor it to their own needs. Each exercise was demonstrated in a video, and the patient's heart rate was monitored throughout. With this in mind, our aim was to repurpose the Fit for Surgery app to deliver cardiac rehabilitation before and after elective cardiac surgery by using the UK double diamond method. To do that, we conducted focus groups with research team, cardiac rehabilitation experts, and cardiothoracic surgeons. In figure 1, you can see the UK Design Council double diamond method, in which ideas are created called divergent thinking, and then narrowed down to the best concept or solution called convergent thinking. The double diamond design process has 4 stages: discover, define, develop, and deliver. And we will discuss this in detail in the following slide. During the discover phase, we held 2 workshops. Workshop 1 consisted of a focus group with healthcare practitioners to map the patient's journey through the pathway, as you can see in figure 2. Here you can see the interactions and touch point from when the patient is first presented with this app, as well as the people he encounters along the way, from pre-op to the day of admission, to the post-operative period and post-operative surgical clinic. Workshop 2 was a focus group discussion with healthcare practitioners to identify major themes and sub-themes as shown in figure 3. Here you can see the 6 major themes: patient education and personalized patient support, behavioral and psychological support, healthcare practitioners' education, and the structuring of resources. Based on insights from the discover phase, we defined the design brief and grouped the solutions into 2 main categories. Category 1 was developing a digital passport or coach for patients to help users feel involved in the pathway and their cardiac rehabilitation decisions. This will include support tools from psychologists, dietitians, pharmacists, and cardiac rehabilitation functioning. The second category is an outcome tracking tool for clinicians to monitor a patient's progress. The app infrastructure should enable connectivity across disciplines and systems and joint primary and secondary care networking. The develop phase includes concept generation, development, and evaluation, as well as developing prototypes and getting participants' feedback on the prototype testing. During the delivery phase, we plan to utilize focus groups and workshops to develop user personas and user stories for both patients and healthcare practitioners. In conclusion, this is the first app development for cardiac rehabilitation using the double diamond design process. The design process highlights the importance of focus groups of patients, healthcare practitioners, and stakeholders with product testing on devices to satisfy usability for patients and healthcare practitioners. Once the intervention development is finalized, we will assess its feasibility to determine if it is appropriate to proceed to a substantive randomized clinical trial study. Thank you.
Very much for that very interesting talk. If I may start the question, there's one coming from Slido, but I'm quite interested in this idea of using technology, particularly now that we've had a year of doing this in the current era with older adult patients. Do you have a sense through your focus groups of what the activation and engagement rates would be for the older adult, we'll say as being over the age of 65 or 70, and using these apps and continue to use these apps to show benefit in the preoperative and postoperative phase?
So for the cardiac surgery side of the app, we haven't been able to hold proper focus groups because of COVID. But in the past, when we've done that for lung cancer patients, the uptake has been quite good, and we were quite surprised that people were very willing to engage with it, and they found it as something new and exciting and something a little bit different, without having the pressure to have to go for an appointment and be in a hospital and be in a certain place. They also found it easier to involve their loved ones at home to put their motivation. So yeah, the uptake has been quite good in the past.
Excellent. Sanjay, do you have a question? I have a couple coming in from Slido, but if you have one, please go ahead.
Yeah, I mean, I just wanted to ask you about the use of this app for prehabilitation, because how do you find the application for that in the prehabilitation?
So when we developed the app, the goal was to develop for both pre and post-operative rehabilitation. So the plan was to show the patient the app when they come for their clinic visit, which tends to be around 6 weeks before they come in electively for their surgery. Show them how to use the app, give them a contact detail from a healthcare practitioner that can keep an eye on them on the app and answer any questions, and just encourage them to do as much as possible before surgery. And I know there's a lot of drive to deliver prehabilitation in the cardiac surgery patients, and we're hoping that this app will help do just that.
Great. And what about patients who come in for urgent surgeries? How do you have anything to include such patients?
We don't. At the moment we don't. When we developed the app, we said we're gonna start with the elective patients, mainly because there were some concerns with regards to what kind of physical activity the urgent patients can do. And by the fact that they're urgent, they would already be in hospital and see a physio and hopefully get their bit of rehabilitation this way.
Brilliant. Thank you.
There are a ton of really great questions coming in through the Slido app here. Unfortunately, we've run out of time for your presentation, but hopefully you can answer them for us in the app, and we perhaps can go on to our next presentation, Sanjay.
Yeah, the next presentation is by Charlotte Holmes, and she's presenting, "Are we helping you to get your kidney? Outcomes of patients awaited kidney transplant requiring valve replacement surgery." Thank you, Charlotte.
Hello, my name's Charlotte Holmes. I'm a cardiothoracic registrar from the North East Deanery. I'm here to present the outcomes of patients awaiting kidney transplant requiring heart valve replacement surgery to see if we are helping them to get their kidneys. Patients with valvular pathologies awaiting renal transplant are often referred for heart valve surgery prior to listing to optimize their cardiovascular function in order to aid in their transplantation. Anecdotally, these patients are high risk for mortality and morbidity and have complicated recoveries. So we sought to analyze the outcomes of these patients to see if they ultimately achieve their kidney transplantation. This is a single center retrospective analysis of prospectively collected data of all patients awaiting renal transplant requiring heart valve replacement surgery from 2009 to 2020, with the primary outcome of successful renal transplantation and secondary outcomes including mortality, length of stay, and post-operative complications. During this time period, 20 patients were identified, 70% of which were male, with an average age of 57 years and a range of 38 to 77 years. 50% were elective and 50% were urgent. 60% of cases were single valve replacements, mostly AVRs. As you can see, 50% of patients were AVRs or AVRs and cabbage. 25% were dual valves, namely AVR and MVR. There were 2 reduced stenotomies and mitral valve replacements, and 1 triple valve AVR, MVR, and tricuspid valve replacement. 2% of referrals were endocarditis, all of which were urgent. 3 were Staph aureus and 1 were enterococcus. The most common pathology, as you can see, is aortic stenosis of 45% of cases. 40% of patients required concomitant procedures at the time of their valve replacement, mostly coronary artery bypass grafts. Mean follow-up was 5.5 years with a range of 6 months to 9 years. Looking at prosthesis type, the most common prosthesis in AVR was Cardiopulmonary mechanical valve. Secondly, Edwards Resilia. The most common valve choice in mitral valve replacement was Carpenter Edwards Paramount. And in AVR and MVR, the most common choice was 2 Carbomedics. 65% of patients required post-operative inotropic support. 5 required reinstitution of bypass intraoperatively for complications including mitral valve replacement following failed repair, paravalvular leak, SVC obstruction, atrial tear repair, and 1 case of bleeding. 1 patient required ECMO, which was an elective AVR and MVR for regurgitation. The patient was on steroids and had a fragile atria which tore, requiring reinstitution of bypass. The patient became vasoplegic and failed to wean from bypass. 15% of patients were re-explored for bleeding. 1 patient needed redo surgery whilst as an inpatient on day 12 for significant paravalvular leak. 90% of patients required CVVH prior to reinstitution of their usual hemodialysis. 20% of patients had pneumonia, 25 atrial fibrillation, and 2 patients required permanent pacemaker insertion. 2 patients developed mediastinitis, 1 requiring wound debridements and subsequent pectus advancement flap under plastics. Average length of stay was 36 days with a range of 6 to 124 days. Mortality was high, 60% of patients had passed away, 3 as inpatients, 1 6 years later following redo surgery as an inpatient. 8 died on the transplant list with a range of 1 to 3 years post-heart surgery. 1 case of small bowel ischemia. 1 case a patient wished to withdraw from dialysis. 1 patient died in a peripheral hospital and awaiting the cause, and 5 patients died in the community awaiting cause. 6 patients remain on the transplant waiting list with a range of 6 months to 6 years wait. 1 patient has been removed from the transplant waiting list as they have become unsuitable due to other comorbidities. 2 patients were successfully transplanted post-heart surgery, 1 of whom has passed away following redo surgery, and 1 who is doing well at follow-up. Therefore, patients undergoing valve replacement surgery prior to planned renal transplantation are a very high-risk group with regard to prognosis. It is therefore paramount to have a multidisciplinary team decision for these patients. Although many patients are referred for heart surgery, only 10% actually achieve the goal of renal transplantation in this group. It's therefore careful patient selection and realism that is important in this challenging group of patients. Thank you for listening.
Thank you very much, Charlotte, for your presentation. Can I just ask you a question before we go to the floor? So, what are your thoughts about surgery in such patients? Do you think we shouldn't be offering them surgery, or do you think percutaneous options are a better option, better option in these patients?
I think that these patients require and deserve a specialised MDT with their renal physicians present. And I think that where alternatives would be offered to the patient, perhaps they should be considered, given the duration of recovery for these patients, their inpatient stay and their complications. I think it's worth considering if it's available.
Thank you.
There is a question from Slido here. You mentioned 90% required CBBH. What did the other 10% have? Sorry, go ahead. Go with the first one first. Yeah.
1 patient had peritoneal dialysis. Some were able to reinstitute their hemodialysis straight after surgery.
Okay, and that may answer part of the second question here is, did you have any patients who did not have CVH or CVBH-DF and went straight to PD?
Yes.
Yeah. Okay, great. Thank you. There is one more from Slido here. Were there any patients turned down from cardiac surgery, hence taken off the renal transplant list?
I do not have that data. I looked specifically at the patients that had gone on to have surgery, but that is something that I could look at as part of the paper.
Great. Okay, yeah. If there are no other questions, thank you very much for an excellent presentation, a very interesting topic, Charlotte, and perhaps we can go on to our next presenter.
Thank you, Rakesh. So the next presenter is Lu Wong, and he's presenting the Northeast Frailty Score, a new comprehensive frailty tool for elective cardiac surgery patients, results of the pilot study. Thank you, Lu.
Hello, everyone. My name is Lu Wong. I'm a cardiothoracic surgery trainee in the Northeast Deanery. It is my pleasure today to share with you the pilot data of this prospective study about Northeast Frailty Score. Frailty is a distinct biological syndrome of decreased reserve and resistance to stresses due to cumulative declines across several physiological systems. It is very pertinent to our specialty, as cardiac surgery is no doubt a major stressor, and frailty is very prevalent in our patient population. Although frailty is recognized as a risk factor for mortality and morbidity post-surgery, it is not accounted for in the traditional risk scoring system, such as Euroscore 2. Therefore, a good frailty assessment will provide additional information for pre-op risk stratification. Most people have been consciously or subconsciously assessing patients' frailty prior to their operation. For example, we pay attention to watch how patients walk into clinic. However, this eyeball assessment can be subjective and rudimentary, as 3 or more criteria need to be met before we can call a patient frail. Most of frailty score reported in the literature only looked at a selected few aspects of frailty. Therefore, we designed this prospective study to examine whether it is feasible to assess frailty comprehensively. We started this project on elective cardiac patients older than 70 years. When they came for pre-assessment clinic, they were asked to complete a questionnaire while they were waiting for their appointments and perform a few physical and mental tasks supervised by nurses. Hemoglobin and albumin levels were part of their routine pre-op blood tests. Therefore, the whole assessment only increased patients' pre-assessment clinic appointment by 10 minutes. 1 point is assigned to each of the 11 items should a patient deemed frail in that test. If a patient scores 4 or more points, they were considered as frail. This project was started in December 2018. All of the patients who had a frailty assessment and undergone their planned operations prior to the end of September 2020 were included. All of the patients at least 3-month follow-up. I performed non-parametric tests to compare the baseline characteristics and the post-op outcomes of the frail and non-frail groups. Kaplan-Meier curve was plotted to assess survival of the 2 groups. ROC curve analysis was used to study the predictive power of each individual frailty test and the Northeast Frailty Score. In addition, I used binary logistic regression to examine the association between the independent variables and the post-operative adverse events. A total of 201 consecutive patients were recruited. 36 of them didn't complete the whole frailty assessments for one reason or another, and are thus excluded. Among the 165 patients, about 2/5 were considered frail by the Northeast Frailty Score. Except that the frail group had higher Euroscore 2, the 2 groups had similar baseline characteristics and underwent a similar spectrum of cardiac operations. However, the frail group had more major complications, longer ITU and hospital stays, more likely to be discharged to a rehab facility, and higher 90-day mortality rate. As shown in the Kaplan-Meier survival curve, the frail group had higher mortality throughout the whole follow-up period. None of the individual frailty tests had adequate predictive power for 90-day survival. However, putting them together, the Northeast Frailty Score provides a good prediction. The binary logistic regression showed that frailty is associated with ITU stay longer than 3 days, hospital stay longer than 10 days, and major post-op complications, independent of sex, age, BMI, Euroscore 2, and type of operations. In fact, except for the significant association between EuroScore-2 and major complications, none of the other 5 factors are predictive of stormy recovery period when they are separated from frailty. In conclusion, this project demonstrated that it is feasible to comprehensively assess patients' frailty pre-op. The Northeast Frailty Score can independently predict undesirable post-operative outcomes. However, we appreciate that this is a single-center study and the score needs to be validated with another cohort of cardiac patients. Nonetheless, this comprehensive frailty assessment tool provides additional information to facilitate the heart team better risk stratify patients and help patients make informed decisions about appropriate treatment option. We are keen to attest this tool in other cardiac departments and surgical specialties, so collaboration is welcome. I would like to thank you for your time, and I'm happy to take your questions.
Excellent presentation, Lou. Firstly, I should apologize. I got your gender wrong, so sorry for that. I didn't realize that. But my question to you is, why did you choose 70 years as a cutoff age? And secondly, in patients who were deemed to be frail, did you turn down patients for surgery if they were too frail? And what were your, if that was happening, then what was your cutoff to turn them down for surgery?
So the first question, when we designed this project, we did debate whether it should open to all of the patients or whether we should have age cutoff. Now the age cutoff was set because at the beginning there was a bit of hesitation in the pre-assessment clinic nurses. They were worried that it will increase a lot of their workload. So which is why we said, okay, at the beginning, we will start with the group which are more likely to catch the frail patients, although frailty and age have no straightforward link. So that's the idea. So actually, last year, we tried to include all of the patients. However, the day we introduced this was the day when the national lockdown started, so that didn't happen. But the project carried on to assess patients older than 70. And now in this project, we didn't turn down patients because of our assessment. In fact, we did it. So all the patients who came to pre-assessment clinic, they already have seen their surgeon, more or less had their operation plan fixed. So it's more sort of to assess whether it is feasible to assess their frailty comprehensively and whether frailty and outcome using this method had a link. So we didn't intervene the surgical decision based on their frailty assessment.
Thank you.
Perfect. So this is a topic that's obviously very near and dear to my heart, and I couldn't agree more that it's time to move beyond the eyeball test. There are several really good questions, and I'll try to chunk them up in sort of some themes. And one of them is choosing the right tool for assessment in a busy clinic. And so what was the time and staff resource required to carry out an assessment on one patient? And was there some patient fatigue that allowed to lack of completion of frailty testing in some patients?
So for the 36 patients we excluded because they didn't complete the questionnaire in one way or another. I think a handful were because the questionnaire was a bit too long, so they just didn't complete it. So I do see the possibility. However, it's a handful out of 200 patients. Another thing is so the nurses. So like I said, they increased the 10 minutes increment was mainly because nurse need to conduct the physical and mental assessment. So during the lockdown, because of the social distancing, that we did observe some patients who couldn't safely assess their frailty because of social distancing. So again, that contributed to the 36 who we had to exclude. However, overall, we think it's better than we predicted. Initially, we thought assessing it comprehensively would add too much and there would be a lot of patients dropped out. But actually, the ratio was not too bad.
Great. We have time for one more quick question, hopefully. And again, I'll try to chunk a few different questions to one from Manraj, Sandhu, and some others. with regards to now moving beyond the eyeball test and taking some of this information, will this help us discriminate or reclassify patients into different risk categories that Euroscore will not allow? And how will it impact upon shared decision-making with patient and caregivers about the best therapy or best options for that patient?
So we hope that first of all, we need to validate this tool. And then hopefully when we go on to the MDT or the heart team discussion, we will have the frailty score at the same time as Euroscore, and at the same time as the other investigation results. So it will be an important factor for the physician and surgeons to consider. And then also when we discuss with patients, there will be patients who are very fit but hesitant to go on surgery, and then we can show them the results with this, what sort of outcome are likely for this low risk group, and vice versa, what's our outcome for the high risk group who wish to carry on with surgery. So I think it will provide more information both for the patients and physicians.
Great, outstanding. Thank you very much. We're going to have to move on to our next speaker. Lots of great questions. Well, again, we'll keep trying to get to all of them.
Thank you. The next speaker is going to be Joseph George, presenting on behalf of Shobrin Sharma on impact of perioperative blood testing bundle on bloodletting and transfusion in cardiac surgery. Thank you, Joseph.
I'd like to thank the Society for the opportunity to present this work on behalf of our department. In routine care after cardiac surgery, we undertake a plethora of blood tests, including arterial and venous blood gases and various blood panels. For example, in our unit protocol, routine blood gases are taken hourly after extubation, following which it becomes less frequent. Routine blood panels monitor the blood counts and renal and liver function. However, these tests utilize not only a large amount of resources, but also can pose some morbidity with respect to the significant volume of blood drawn from patients, albeit incrementally. Our aim was to assess the impact of introducing a blood testing care bundle in the perioperative period and to evaluate the resultant anemia and blood transfusion requirements. One of the key elements was to introduce a closed sampling system that would be connected in line to the invasive monitoring line. Normally, the nurse would withdraw 5 ml of discard blood to clear the circuit of any contaminants before withdrawing a 1 ml for the blood gas measurement. This system withdraws the initial 5 ml of blood into a sterile reservoir before sampling, after which the 5 ml of red blood is reinfused into the patient, thus minimizing loss. This was a prospective study. We initially undertook the study over a 6-month period, introduced the bundle, and repeated the study over a further 10 months. We collected data regarding blood volumes due to blood tests from the hospital pathology database, ICU charts, and sample bottles. Transfusion data was acquired from the blood bank. This graph shows the various test bottles and volumes required for them. There were approximately equal numbers of patients in both arms, Group A being pre-intervention and Group B being post-intervention. They had similar demographics and operations. Of note, there were slightly more isolated coronary operations in the first group and slightly more combined valve and coronary operations in the second group. And the second group coincided with the pandemic. Here we can see that the average number of blood panel tests per patient are similar. However, there is a significant decrease in the number of blood gases and the volume drawn from the patient due to the blood gases. Pre-intervention, the total average volume drawn per patient was 413 ml per patient and 169 ml after the bundle implementation. Only 30 ml was lost due to blood sampling after implementation, compared to 278 ml, almost a 9-fold difference. There were fewer blood transfusions after the bundle implementation, and the resultant costs were substantially lower. On average, 2.8 units were transfused in Group A versus 2.1 units per patient in Group B. This worked out to be £420 and £319 respectively, a saving of 25% on each patient. We have demonstrated in summary that this bundle has reduced the volume of blood drawn from patients in the perioperative period, with an associated reduction in blood transfusion requirements and significant cost savings. Blood conservation includes preoperative optimization, surgical approaches, conduct of cardiopulmonary bypass, and transfusion protocols, and optimization of all of them. Through this bundle, we have demonstrated how a simple scrutiny of blood testing in the perioperative period can have significant impact clinically and financially.
A very, very interesting talk. We're just waiting for a few questions to come in through the Slido app here now, but thanks very much for pinch-hitting, Joseph, on behalf of your colleague. The first question I have here is really excellent and really deserved study. Thank you for this cost analysis. This is from Karen Booth. What advice would you give to other units trying to implement this work? I think it's a great question. You may be on mute there, Joseph.
Can you hear me? Yeah, sorry about that. So I would say that actually this study looked very little change in effort, but most of the time it took more a conversation with the ICU matron in charge, with the anesthetist and with the intensive care team to change the protocol of the bloodlet of the sampling. Secondly, it took some effort in terms of acquiring a new device to be used in ICU. But obviously, the alternative is to have a system whereby you can reinfuse the blood drawn as discard back into the patient. And I'm aware that there are some units which already do that in some centers, but there are also many units which do not. And therefore, this is a great way of suddenly getting some cost savings as well as clinical outcomes improvement.
Right. Just seeing a comment here from Slido again from Rachel Williams. Once the nursing team were comfortable and confident with the equipment, it was plain sailing. I guess to add further commentary to your question. Great. I don't have any other questions coming through Slido right now, but my question really was on the knowledge implementation component as well in terms of the time frame and the education platforms you would have had to use to get as wide of a net to catch as many of your team as possible. Any thoughts of how one would do that?
I think it's, I don't think there are any secret formulas. It's just talking and getting ideas and involving the people who are going to be using the system and then explain the benefits of the system and then thereafter implementing it. I think it's just with any other change, you have to get people on board on what you want to achieve and go with them. You know.
Yeah, I think the cost savings you're showing are really quite impressive, and just in general, decreasing the overall vampirism we do in the perioperative space, I think, is important. So well done on the study.
Thank you. And then, if anything, I think we've underestimated how much we've saved, and to be on the conservative side, I think.
Great, fantastic.
Thank you. Thank you. Shall I introduce the next speaker?
Please, yes.
Okay. So the next speaker is going to be Luke Rogers and Ricky Vaja on interventions to prevent surgical site infection in adults undergoing cardiac surgery, Cochrane review.
Good afternoon, ladies and gentlemen. Firstly, I would like to thank the chair, the SCTS, and the team of individuals behind the scenes that have finally made it possible to present this work at the first SCTS virtual conference. I'm presenting on behalf of an interdisciplinary steering committee of 14 individuals that through the Cardiothoracic Interdisciplinary Research Network, or CIRN, have written a Cochrane review on the interventions to prevent surgical site infection in adults undergoing cardiac surgery. This is an especially important topic because surgeon site infection occurs in approximately 10% of individuals undergoing coronary artery bypass grafting. It is associated with a tenfold increase in mortality, increases readmission and reoperation. It costs upwards of an additional £30 million per year, and there is currently no standard of care for the prevention and treatment of SSIs in cardiac surgery. No one has collated and reviewed the evidence that exists, and that's what this Cochrane review set out to do, by identifying and highlighting any uncertainty and knowledge gaps that may exist. The search was performed in accordance with the standards set out in the Cochrane Handbook and included the usual databases, clinical trial registries, and a search of the grey literature. Inclusion criteria included all adult patients undergoing cardiac surgery that were included in a randomized controlled trial, interventions that were principally implemented to reduce surgical site infection, and alongside surgical site infection, both superficial and deep, outcomes included mortality, length of stay, readmission, reoperation, and adverse events, which is a requirement for all Cochrane reviews. Over 4,000 articles were identified, and 95 have been included. Interventions were categorized into those that were pre-operative, intraoperative, and post-operative, as you can see here. In this presentation, however, we will focus on a brief snapshot of some of the most interesting results. For further information, I urge you all to review the Cochrane review when published, hopefully towards the end of this year. Pre-operative decontamination, including that for MRSA and MSSA, demonstrated no difference in the incidence of SSI or all-cause mortality in the 3 included RCTs. It is, however, important to note that these were very small samples with low event rates. The direction of treatment effect for glycemic control appeared to be in favour of tight glycemic control in relation to both the incidence of surgical site infection and all-cause mortality. Mortality was, however, driven predominantly by a single study, Blaha 2015, which included over 1,200 patients. Associated with this, there may also be an increase in the hypoglycemic events or adverse events, and this remains an area of uncertainty. Overall, tight glycemic control may reduce surgical site infection and all-cause mortality, but the optimal regime to avoid hypoglycemia remains uncertain. Topical antimicrobials in the form of gentamicin collagen sponge appears to show a positive treatment effect in favour of its use, both in relation to the reduction in superficial, deep, and total surgical site infections. This does not, however, translate to an improvement in all-cause mortality. Negative pressure wound therapy also appears to show a positive treatment effect in relation to the reduction of surgical site infection. However, as you can see, again, this was very few studies, 3 randomized controlled trials, including both very small samples and a low event rate. This figure highlights the cumulative risk of bias of included trials across all fields: selection bias, performance bias, detection, attrition, reporting, and other bias, notably the pre-operative, the pre-systematic review inclusion of a protocol. 10% of the studies were at high risk of bias in at least one of these aspects. Blinding of outcome assessment was performed in only a third of trials, and risk of selective reporting was unclear in approximately 50% of trials. So, to conclude, 21 interventions have been implemented to reduce surgical site infection after cardiac surgery. The randomized controls that currently exist in published literature are of low quality and high risk of bias, generally as a consequence of their small sample sizes and the heterogeneity between both intervention and outcome measures, basically meaning that none of the trials included, or very few of the trials included, were powered sufficiently for the measure of surgical site infection. This work has highlighted a huge knowledge gap in the evidence for interventions to reduce surgical site infection, and it has emphasized some interesting areas for research which may prove beneficial, notably glycemic control, decontamination, and the use of topical antimicrobials and negative pressure wound therapy. This work, alongside other work by the CIRN, notably the Variation in Practice Survey, has underpinned a successful NIHR program development grant application, which work will start on in the next 3 months. This will require local associate principal investigators to deliver. So if you're interested and the work that we have done so far interests you, we'd be very much like to hear from you. Now is your chance to get involved. Please email the CIRN network at outlook.com to learn more. Thank you for your time.
Excellent presentation and really important work, and congratulations on getting your grant. I think this is excellent work. I'll start with our co-moderator, Sanjay, if you have any questions to start with. Mr.
Yeah, thanks, Rakesh. So Luke, I mean, we all know that the SSIs are multifactorial, and I think there's a lot of interest in negative pressure dressings, which has come up in the last few years. I don't think there's much publications with regards to using pico dressings electively in patients. Have you got any information or knowledge about that?
So there's one trial on pico dressings that has recently been published, and that is included in the Cochrane review. It has a very low event rate, but it did appear to show that there was some demonstration. The caveats with that you have to include for Cochrane is that it is a industry-funded RCT. There is currently no other RCTs that have been included from researchers in healthcare as opposed to industry-led studies.
Okay. And the other question is, a lot of North American surgeons use vancomycin paste with all these surgeries. Do you know anything about any? Does any of publications represent that in your Cochrane review?
We looked at including vancomycin paste, and it was the initial sort of intervention group was just topical antimicrobials, but there was a preponderance towards the gentamicin collagen sponges as opposed to the vancomycin pastes, and that was simply because there's no randomized control trials that have looked at the vancomycin paste.
Thank you.
Can I ask one more quick question before we run out of time here? So the one study you mentioned that was actually a reasonable sample size was the Baja study on glycemic control.
Yeah.
We have tried and failed impressively so trying to develop a preoperative optimization clinic or an outpatient clinic for patients with diabetes who have poor glycemic control. How do you think, and it's a bit beyond your review, but how do you think you would target that specific higher risk population where there does appear to be some signal?
So I think one of the challenges with cardiac surgery, and this is across the board for a lot of the talks we've already talked about, is that the vast majority of the patient population, maybe 50 to 60%, is urgent cases. But for those that, and you've got to treat them both slightly differently. I think in the elective setting, it'd be much easier to identify these patients that are at high risk, and this goes true for diabetes, renal failure, all of those comorbidities that we are aware of, to then medically optimize them preoperatively in their run up to their expected date for surgery. I think and that's reasonably straightforward, and the infrastructures are already in place for those sorts of issues, although things can always be improved. The challenge is to identify and try and improve the outcomes for those patients that come through the urgent setting, which is the majority of our patients. And I think the only way really of doing that is to the surgical part of it is almost the most straightforward part, because it's the same for every single patient almost, and then it's really around making sure that their post-operative care is maximized and standardized towards ensuring that these things are limited as much as possible. To do that, we have to be actively involved with our anesthetic colleagues on intensive care and oversee these patients throughout their ward stay to try and develop that maximization that we achieve in the elective setting.
Great. Thank you very much. We're going to have to move on to our next presenter, I think. Thanks very much, Luke.
Thank you, Luke. So the next presenter is Sewerage Patek on pharmacological interventions for the prevention of renal injury in surgical patients, a systematic literature review and meta-analysis. Thank you, Sewerage.
Good afternoon. I'd like to thank the committee for giving me the opportunity to present our systematic review which focuses on the efficacy and effectiveness of pharmacological interventions aimed to prevent renal injury in surgical patients. Just to give a brief background, acute kidney injury occurs in up to 1/3 of patients following cardiac surgery. AKI following heart surgery is associated with a fourfold increase in the risk of death, and the latest Cochrane review failed to demonstrate any clinically effective renal protective interventions. The key research question was therefore whether there are any concomitant interventions in the perioperative period that can reduce the risk of renal injury, and do these in turn result in improved post-operative outcomes. We performed a systematic review of randomized controlled trials using Cochrane methodology. The protocol was registered in Prospero, including all patients undergoing all types of surgery except those undergoing resuscitation for burns, critical care patients, patients with GI hemorrhage, patients undergoing transplant surgery, those undergoing surgery of the urinary tract. We included all pharmacological interventions. Their primary outcomes were AKI and mortality. Secondary outcomes included renal function, morbidity, and resource use. Subgroup analysis was conducted which assessed whether the treatment effects interacted with clinical settings such as vascular surgery, cardiac surgery, or general surgery. Sensitive analysis was also conducted which included studies which were at a high or uncertain risk of bias in any one of the domains of the Cochrane risk of bias tool. Initial searches revealed a total of 3,625 papers. After further shortlisting, this led to 228 RCTs with a combined cohort of approximately 56,000 patients. Altogether, we found 22 different intervention categories. They were then grouped in whether they had a beneficial, harmful, or neither effect on the co-primary outcome measures. Interventions that had a statistically significant benefit on the co-primary outcome measures of mortality and AKI included atrial natriuretic peptide, alpha-2 agonists, iron dilators such as levosimendan, vasopressors, calcium channel blockers, and nitric oxide donors. Interventions that demonstrated a statistically significant harmful effect against statins, spironolactone, and restricted flow therapy. All remaining interventions demonstrated neither a beneficial or harmful effect on the co-primary outcome measures. Our analysis showed that ANP analogues are renoprotective, resulting in important reductions in mortality and frequency of renal replacement therapy. These effects were consistent across the cardiac surgery and vascular surgery subgroups, as well as intensivity analysis of restricted studies at low risk of bias. Levosimendan, which is the iron later, reduced mortality, AKI, and RRT, both in the primary analysis and cardiac surgery cohorts. Vasopressors reduced AKI in the primary analysis, as well as reducing AKI and bleeding ICU length of stay in general surgery cohorts. Nitric oxide donors, after agonists, calcium channel blockers reduced AKI in the primary analysis, but these effects weren't observed after exclusion of those studies that increased risk of bias. Restricted flow therapy and spironolactone increased risk of AKI. The broad scope of this review was its key strength, and it was able to provide us with key mechanistic insights. The review was limited by the quality of studies and by the small numbers of patients, including important subgroups and sensitivity analysis. This review identified 156 new papers since the last Cochrane review, but only 10% of these trials were considered to be high quality, and this underscores the need for high quality trials to address the remaining areas of uncertainty. These limitations also prevent us from making firm recommendations as to beneficial treatments. Our review also highlights further important areas of research. We found that ANP appears to have a generalizable renoprotective effect on patients undergoing surgery, but most of these trials were conducted in Japan. Whether these findings will be translated to other ethnicities was unclear. We also found that vasopressors and iron dilators such as levosimendan reduced AKI and renal replacement therapy, but the comparative risk and benefits of these approaches is also unclear. Our analysis highlighted the disconnect between interventions that affect that change in creatinine clearance and those with consistent treatment effects on AKI mortality and renal replacement therapy. A key research question is therefore whether evaluating effects on renal function is the correct approach. Thank you for listening.
Excellent presentation. Just waiting for a few questions to come in from Slido. If I may get the ball rolling, though, one of the risk factors you mentioned was the use of, I guess, potassium-sparing diuretics as well as restricted fluid therapies. And we often have this balance in the perioperative phase of the Goldilocks of having too much fluid or too little fluid. And I often refer to some of my colleagues as the aquatic assassins, as I think we give too much fluid. So how do you suggest, based on these reviews, that we find the appropriate balance on fluid therapy? You may be on mute there, Suraj, sorry.
Sorry, can you hear me now?
Yes.
Can you hear me? Yeah, perfect, thanks. So I think with this systematic review, there was a high proportion of studies that were quite poor quality. Only 10% of the studies were high quality studies. And the studies that were there was quite a lot of heterogeneity. In terms of the two interventions that really showed any sort of benefit was atrial natriuretic peptide and the iron-related levosimendan. And out of they both showed benefit in cardiac surgery cohorts. But the issue with the ANP intervention was that a lot of the trials were done in Japan. So I think the two issues that we need to sort of overcome is to have more high quality studies, and then also to have studies of ANP within Europe and the US.
Mm-hmm, mm-hmm. Good. I'm going to check on Slido see if we got any questions coming in here. I know, Sanjay, if you have any questions for Suraj?
Yeah, Suraj, you also mentioned that stopping statin therapy probably reduces your chance of need for renal replacement therapy or kidney injury. Do you know how many days before surgery you should stop it? Or
unfortunately, we didn't really look at how many days before in the studies, how often before the surgery, how many days before surgery they stop the statins. So it's something we'll probably look at in sort of going forward.
Great.
Thank
There's
you.
one of the question from the Slido group here. Do you have any cardiopulmonary bypass data in terms of times, off pump, et cetera, on all the studies that you have analyzed?
Unfortunately, we didn't really look at those sort of covariates of the study, but it's again something we'll probably look at if we redo the systematic review.
Great, perfect. Thank you. Okay. Thanks very much for an excellent presentation, and we look forward to hearing more about this as we go forward. And perhaps, Sanjay, we can go to our
Yes.
next presenter.
Thank you, Sewerage. The next presenter is Shobrin Sinha, and she's going to present Machine Learning Improves Mortality Risk Prediction After Cardiac Surgery, a Systematic Review and Meta-Analysis.
Hello, my name's Shobrin Sinha and I'm a cardiac trainee in the Southwest Deanery. I'd like to thank the Society for allowing us to present the results of our recent meta-analysis today. We looked at the role of machine learning in potentially improving risk prediction after cardiac surgery. I'd like to thank my co-authors for their contributions to this work. We have no conflicts of interest to declare. Risk stratification in adult cardiac surgery has transformed a lot over the last few years, going from using an additive model such as the Parsonet score to now a logistic regression model, the latest version of which is the Euroscore 2 or the STS score in America. However, despite these improvements, these models have been shown to overestimate risk, especially in those at highest risk from surgery. This may lead to risk-averse behavior or inappropriate counseling of patients. Statistically speaking, these models cannot account for nonlinear interactions between an input variable and an outcome, nor for confounding between variables without the input of the person creating the model. They also would require retraining from time to time, again manually. We hypothesized that modern machine learning algorithms may provide an advantage over the traditional logistic regression model, primarily because they enable rapid and automated assessment of large volumes of data that are now easily available through electronic patient records, and they can themselves account for complex interactions between variables and the outcome. However, this does come at a cost in that they do require very large data sets, large number of events, in our case deaths, to occur to be able to avoid an accuracy paradox, and also the temptation of the person creating the model to put in multiple inputs and therefore risk overfitting the ultimate result. We did a literature search which showed that there were 15 papers going as far back as 1997 and up till the present point of the analysis of 2018. Most papers reported on outcomes in CABG and were done in a retrospective manner. However, you can see there's a wide geographical area over which the results are spread, with also large variations in the sample size and the mortality associated with it. So they also used many different machine learning techniques, some of which are represented here. The most commonly used was a neural network in 12 papers, but some also did use tree-based algorithms or the support vector machine. All papers also reported on a retrained logistic regression model using their own data, and 6 performed comparisons with existing scoring systems. Due to the heterogeneity, we decided to compare the best machine learning model in each paper with the retrained logistic regression model in that same paper using the same variables, and found that there was a statistically significant improvement in the discrimination using a machine learning technique. However, when you're looking at individual models, there was a trend towards better performance in the machine learning arm. However, this was not statistically significant. The improvement in discrimination was more prominent in papers published after 2010 and in those models that were designed using internal validation and larger sample sizes. When we remove studies at high risk of bias, however, the advantage of machine learning over logistic regression techniques was reduced. It is notable that both the ML model and the retrained logistic regression in the 6 papers comparing these two, Euroscore 1 and 2, did show them to have improved performance. So we can see that machine learning models tended to have better discriminatory power than logistic regression in terms of mortality prediction after adult cardiac surgery. The improved results in the more recent years might be due to the presence of larger electronic patient records or more advanced software able to perform more complex algorithms such as ensemble models, and larger studies of these would be required to study it in more detail. We acknowledge some limitations of this study, namely a significant heterogeneity between the models, as well as the translation of this improvement in discrimination into a clinically relevant outcome. Some of these more clinically relevant outcomes may be reporting of a calibration or the a decision curve. However, this was not done in the majority of studies that we reviewed. And also the variable selection in each paper was different. So in conclusion, we feel that machine learning may provide better discrimination when looking at mortality prediction following adult cardiac surgery than logistic regression models. However, further studies of larger data sets with a greater number of events are required. And ideally, these should report on calibration, reclassification, and decision curves in order to be able to properly assess their clinical utility. Thank you very much for your attention.
Excellent presentation again. Just waiting for a few questions to come in through the Slido app again. I will say that I'm intensely interested in this field. I understand it at a very beginner level. And I think when you build these models for machine learning and the algorithms that get produced are based on a number of factors, obviously in terms of preoperative patient factors and so forth. As per the title of this particular session around quality improvement, a lot of those factors that may impact post-operative mortality, specifically things like failure to rescue, where you have an unintended complication from a potentially modifiable risk factor, is really somewhat based on the culture that exists in a particular perioperative unit. And how does machine learning try to incorporate some of that information, or can it in any way incorporate that information of how a team functions?
So it's a really good question. I think the nice thing about the different algorithms is that they are able to handle a really large volume of data. It's just a question of us providing that data to the machine for it to work through its black box. So at the moment, the data that we've used for our onward research is that's routinely collected by the national bodies. And those tend to be preclinical and a few intraoperative details. But as you say, a lot of it is in the nuance of the interactions between the different clinicians involved, the different subspecialties involved, things that happen in theatre that we don't really account for in our databases, for example, and the fact that a patient's risk can change during an operation, during their ICU stay, which are not accounted for by preoperative factors, which is what we tend to focus on at the moment. And I think the other thing that came out of the session that was on Sunday was we talk a lot and focus a lot of our prediction modeling on in-hospital mortality, but actually probably what we need to be doing, apart from gathering all of this information through multiple currently unlinked databases, plus a few soft signs that we need to try and incorporate, is also look at other things such as where they are discharged to, how long they're in hospital, and other morbidities that may have more of an impact on the patient and their family than actually just mortality. And this is the perfect kind of tool to sort of throw as much information to as you can, and then allow it to process it much more efficiently than a traditional logistic regression model would.
So one of the questions that dovetails into this point that you just made, we have enormous amounts of data within the NHS that are so underutilized. As most units do not have an EPR, who do you think should take the lead on collecting data?
That's a very good question. The first year of my MD into this was spent trying to gather data from various different bodies, so I understand the ethical dilemmas and the difficulties involved with the logistics of this. I think that I think it sort of needs to be led from the top. So SETS and the NHS England, I think, should be encouraging these databases to be linked, or at least linked for research purposes alone. I think there are understandable issues around data protection and patient identity protection. But, if people are on Facebook and you can find out everything about them from cradle to grave, the NHS should be able to try and do something similar. And it would be great if the national bodies would try and encourage that to happen, to try and encourage research from basically a very large selection of databases that are there, but just aren't speaking to each other.
Very good. Thank you. Excellent.
Thank you.
Sanjay, I'll turn it back to you there.
Okay. So I'm going to now introduce Dr. Rakesh Arora. He's one of the senior consultants at Winnipeg, Canada, and he's going to give us a talk on enhanced recovery after cardiac surgery with focus on frailty and prehabilitation. Thank you very much.
Hi, my name is Rakesh Arora. I'm a cardiac surgeon and intensive care medicine specialist at the University of Manitoba in Winnipeg in Canada. I'd like to thank the committee again for the privilege for speaking to you today on this topic that I'm increasingly passionate about. I have these disclosures, which have no direct relevance to this talk, other than I will be talking about nutrition, but I will not be speaking about any specific products or any off-label use during this presentation. I'd also like to thank my perioperative team with surgeons, intensive care medicine specialists, anesthesiologists, and others at the St. Boniface Hospital. When we're going to talk about the issues we're addressing today, everything is really a team sport, and I could not do, or we could not have done anything without functioning as a team here. And so our surgeons, the intensivists, and so forth are generally interested in doing the right thing every day, which makes my job a lot more fun and a lot easier. The concepts I think that are most important to talk about today is this issue of frailty, which is best described by this nice diagram from the Frailty Care Network from the UK that shows this balance between frailty and resilience in the older adult. Frailty is really the vulnerability of your patient to specific stressors, be it infection or surgery, balanced with resilience, or the patient's ability to bounce back from that particular stressor or illness back to the level of recovery that gives them an adequate quality of life and functional independence. While we've been lamenting our patients are getting older and sicker for the last 2 decades, I think this is now in our backyard where we're dealing with patients routinely over the age of 70, 80, and now into the 90s regularly. As a result, the way we've managed patients 20 years ago with patients who were relatively younger, less frail, and had less comorbidities may not be relevant in the current era. And therefore, we need a more comprehensive plan to address all the potential vulnerabilities of a patient that may lead to bad outcomes after cardiac surgery. I don't want this to be a data dump where I'm just showing slide after slide of various graphs, because I think for this purpose of a 15-minute talk that we should focus on the main elements that are important for your teams to address with regards to frailty as pertaining to prehab and nutrition. However, I will refer you to this document that was put out about 2 years ago for the Enhancing Recovery After Cardiac Surgery Society, where there's a 22-step point plan that's itemized with various recommendations for your team to look at. This is divided into the intraoperative, but as well as the preoperative and post-operative phases of care to address all these vulnerabilities in the older adult. When looking at these 22 steps for most teams, including ours, it's a bit daunting to understand how you're going to address all of these. There are many elements within that 22-step point plan where you may be doing those elements well already. That this might require tweaking or refinement. There may be other ones that are new. What we chose to do at our site is start with the ones that we already felt a high degree of team engagement on and build upon those to get us an early win, and then use that to build on further as we went down the road. So specifically in the areas of frailty and delirium is an area that I've worked in for a while. And so those are the ones we chose to start with, as well as leveraging nutrition, which is an increasingly important problem from our patients, as they've told us as an issue to address in the perioperative period. So we'll talk about frailty and how to optimize that in the perioperative period. So as we've already defined frailty, the majority of how we look for frailty is usually the eyeball test. You look at a patient up and down and go, you look frail or you don't look frail. I think the example shown for you here with a patient, that's a pretty obvious patient who probably won't thrive after cardiac surgery. The reality is the majority of patients aren't that obvious, and it takes more than just the eyeball test to identify frailty in your patients. There are a number of tools out there to help screen frailty in your patients, and I don't have time to go through all of them, but doing something rather than nothing is likely of benefit. And while many frailty tools or our assessments at the bedside may focus on the muscle loss or cachectic patient, in other words, known as sarcopenia, that's one element of the various domains of frailty, which is addressing just a biologic. Now, also the psychosocial includes cognitive issues, mental health issues, as well as social issues such as social supports and socioeconomic status and inequalities also round out this Venn diagram here for frailty. When you're looking for frailty in your patients with using, again, any number of tools that are out there, about 50% of patients coming through for non-emergent cardiac surgery can be deemed frail. So that's a high number of patients with vulnerability that don't have a comprehensive plan to address for the vast majority of us. Why does this matter? If you have frailty in a cardiac surgery patient, it's associated with worse outcomes, specifically major adverse cardiovascular and cerebrovascular events. To put this in a pictorial diagram, I've got this flow chart or this cartoon up here where we talk about patients who have a high degree of independence versus low level of independence. There are two patients indicated here, one in a green bar, one in a red bar. This dashed line here in the middle of the screen or this diagram is showing that functional capacity threshold. Below that particular threshold, a patient will be largely dependent on others for activities of daily living or instrumented daily living, such as toileting, grooming, cooking, cleaning, and so forth. Our goal is to keep people well above that functional capacity threshold when coming through for cardiac surgery. In this particular diagram, you can see the patient indicated by the green line is someone with lower levels of frailty, or said differently, higher levels of resilience. And you can see they're starting at a higher functional ability at baseline. When they have a major illness, in this case it's indicated by urinary tract infection, but you could substitute cardiac surgery in there just as easily. They have a predictable drop in function that's relatively short-lived, and then they bounce back to their baseline in relatively short order. Compare that with the patient further down, who does not have the appropriate compensation, where they start a lower degree of functional capacity at baseline. They have a longer and deeper dip in their functional capacity following this major illness, or in our case surgery, that lasts much longer, and they never get back to their baseline function. In the worst case scenario, they stay below that functional capacity threshold and never get back to an independent quality of life, which would be a negative outcome for our patients. In addition to loss of functional independence, frailty is also associated with mortality, as I mentioned. If you have a frailty identified using any number of those tools that are out there, it's associated with a 5-fold increase of major adverse cerebrovascular and cardiovascular events following cardiac surgery. So it behooves us to look to how to address these patients. And where a lot of our attention is focused on the post-operative patients, I'm going to turn this a bit to the pre-operative phase to see how we can optimize our patients in that waiting period for surgery. In Canada, we have wait lists. I imagine there are some jurisdictions elsewhere in the world, including the UK, where this exists. So taking advantage of that waiting period of time, we have the opportunity for prehabilitation or new prehabilitation, which is a mixture of optimizing nutrition, cardiac risk factors, providing an exercise program that's tailored to the patient, as well as dealing with issues of stress and anxiety or mental health issues. I'm going to focus primarily on the exercise and nutrition component today, but know addressing all three of those domains are really important for addressing the various domains of frailty for your patient. On this diagram here, again, we've got the frailty risk factors shown for you on the left side, where there's genetic factors, age, comorbidities, life stresses that all produce some degree of frailty that can be seen as a continuum. The majority of patients we operate on aren't typically the highly frail patients, but usually those patients are vulnerable to mild frail category. Again, using the eyeball test may not identify frailty in these patients, so using a screening tool is of benefit to identify potential risk in your patients. For us, at least until recently, we didn't have a dedicated program to address frailty while they're waiting for surgery, which can be several days or weeks, depending on the type of procedure they're meant to undergo for cardiac surgery. In our past, our patient would look like this patient indicated in the purple bar, where they had standard care. Well, while they're waiting for surgery, they're not prescribed any specific exercise, nutrition, or other. When they come through for their surgical procedure indicated by the vertical dashed line, you can see there's a predictable drop in function again. In a patient that is vulnerable or frail, that dip may be below that functional capacity threshold again. And in this example, the patient never got back up to their baseline and stayed below that functional threshold capacity, indicating they will require some dependency on their activities of daily living following hospital discharge, or actually may require a transfer to a skilled nursing facility or long-term care facility. Contrast by that patient in green, where we provided a new rehab program, which again is a mixture of nutrition and exercise. The exercise component should be theoretically tailored to your patient, that has a mixture of both aerobic and resistive type training that's limited by their cardiac disease and symptoms, that we're refilling that patient's fuel tank to basically build up resilience to that patient. So when they undergo the stress of surgery, while they do have that predictable drop in function, they recover a bit more quickly and are certainly above their baseline now that the cardiac disease is corrected. That's really the goal we're trying to achieve with prehab prior to patient surgeries, to have better outcomes afterwards. There's not a lot of data, nor is there a standardized way in which we're meant to provide this to patients. So we have to extrapolate a little bit from non-cardiac surgery literature. There have been 2 randomized trials, a relatively small sample size in single centers, indicating that prehab is safe in patients with uncorrected cardiac disease, and it may lead to improvements in hospital length of stay, improved exercise capacity, improved attendance in post-operative cardiac rehab, which is also important, and overall patient satisfaction. So switching gears a little bit from the exercise component towards a nutrition component, which really does need to be paired to provide the maximum benefit for your patients undergoing cardiac surgery, this diagram indicates why that component is of importance. So in addition to having the disease state of the cardiac disease state that limits their functional ability due to angina or shortness of breath issues, this leads to worsening issues of muscle loss or sarcopenia in a patient that's already starting with some degree of frailty. With that, they end up walking less and expending less energy as a result because of fatigue and symptoms. That leads to less intake of food that may lead to a chronic undernutrition state. This undernutrition or malnutrition, again, unlike the example that I showed earlier where it may be obvious, is not terribly obvious in the majority of patients. And it's really defined as an unintentional imbalance of nutrients, both protein and micronutrients, that lead to this malnourished state. How common is it? Well, if you look at hospitalized older adults defined as over the age of 65, this is from the Canadian Task Force on Malnutrition, but 40% of older adults coming to hospital have some degree of malnourishment, again, defined by an imbalance of nutrient intake over a prolonged period of time. In cardiac surgery patients, about 1 in 5 patients can be deemed malnourished if one looks for it using, again, one of a number of different screening tools out there for malnutrition. Why does this matter? Well, in addition to their cardiac disease of chronic heart failure and anemia and low metabolic reserves, when they undergo surgery, we often starve them. So either by preventing them from eating from the day before or at midnight before the surgery. In addition, if they have their surgery canceled and so forth and have multiple days of fasting prior to surgery, it further compounds this chronic nutrition problem with an acute nutrition deficit in the course of their operation. Why does this matter? Well, if you have malnutrition in a patient undergoing cardiac surgery, certainly it's associated with worse functional recovery, higher rates of infection, longer hospital and ICU length of stay, but also increased mortality. Thankfully, it doesn't take a lot to correct this nutrition deficiency. And again, extrapolating primarily from non-cardiac surgery literature, 7 to 10 days seems to be sufficient to provide adequate nutrition supplementation while waiting for surgery. Importantly, this should be in the form of protein calories. So protein calories over total calories is a mantra that your nutrition team should look at for your patients going in through for cardiac surgery. And as a result, we're recommending this as part of the ERAS guidelines to find opportunities to optimize your patients preoperatively. This is a much more elaborate process by Paul Wishmeyer from the Duke Group and their Perioperative Enhanced Therapies Pathway, where they have a preoperative nutrition score they use called the PONS tool, which I can talk more about later on. When they identify someone with risk, they undergo a pathway of high protein and vitamin supplementation. While in hospital, this nutrition continues using immunonutrition. Again, I won't talk about that in the talk today, but happy to talk about during the discussion period in more detail. Importantly, when they leave hospital, to continue to treat this catabolic state generated by cardiac surgery, they continue this protein supplementation for several weeks following cardiac surgery or following surgery in their particular center. So in addition to dealing with a chronic undernutrition problem with protein supplementation, I also talked about how we often fast patients prior to surgery. Again, we have until recently had people not eat or drink anything after midnight prior to the surgery. And as we have wait lists and sometimes cancellations, particularly in this area of COVID, this was potentially leading to multiple days of fasting for our patients. In non-cardiac surgery literature, this is old news where they're giving complex carbohydrate solutions up to 2 hours prior to surgery to refill that fuel tank prior to undergoing surgery. This has been relatively a new development for us in cardiac surgery, and as such, we're now recommending that we use a complex carbohydrate such as one that's rich in maltodextrins that has a lower glycemic index with 100 grams a night before and 50 grams 2 to 4 hours prior to cardiac surgery. Initially, this may seem counterintuitive for patients with the high rates of diabetes and potentially gastric outlet emptying difficulties and the routine use of transesophageal echo in several cases. However, data would show that this is both safe, reduces GI complications overall, improves insulin resistance, improves post-operative glycemic control, and enhances return of gut function. There are some specific studies coming out looking at exercise and nutrition in a cardiac surgery patient in a multi-center trials, one specifically in TAVR patients and one in overall in all cardiac surgery patients with some degree of frailty. We hope to have this data for you in the near future. Okay, with there, I'm going to stop and summarize. Frailty is common. About 50% of our patients have frailty if you look for it. If they're frail, in addition to difficulties with functional independence, there's high rates of MACE or 5-fold increase of MACE associated with frailty in patients undergoing cardiac surgery. We therefore need to identify risk in our patients using some sort of frailty tool to see those patients who are vulnerable, and then seek opportunities to optimize them in a mixture of nutrition, exercise, and dealing with stress and mental health issues prior to surgery. It's yet unclear that we should delay surgery to optimize these patients with a prehab process, but preliminary randomized trials would suggest that it's safe to wait in patients with uncorrected cardiac disease while providing a prehab program while they're waiting for surgery. So again, I think we have older and sicker patients, and we therefore need to look at this as an opportunity to provide a more comprehensive plan for our patients to ensure the best outcomes for our patients. With that, I'd like to thank you very much for your time, and I'm happy to take more questions during the discussion period.
Excellent presentation, Rakesh. I don't have access to the Slido. Are there any questions on the Slido?
Yeah, I have a couple here. One is from Haider Mohammed. How do you assess frailty pre-op in your practice and any specific score you adopt? So I guess the simple answer to that is we use the clinical frailty scale as a starting point, which is developed from Ken Rockwood's Frailty Index, where there are basically a semi-quantification of different frailty cut points based on that large Canadian study over healthy aging as a starting point. When we identify someone with that relatively broad and we'll say not terribly specific tool for cardiac surgery, we use that to then hone down to more specific testing for that patient, either through a formal dietary consult or geri rehab consult in the preoperative setting. There are multiple tools out there. At the end of the day, you have to choose one that is most feasible within your clinical context, because doing any frailty testing is probably better than doing nothing. So finding one that fits is probably the most important aspect rather than the specific tool in and of itself. The other question we have here does from Uday Trivedi, does minimally invasive surgery mitigate some of the negatives of being frail, or is the need for cardiopulmonary bypass a bigger factor than the size of incision? And I think it's a great question. I don't know that I have a great answer, but in general, doing minimally invasive surgery where you have less surgical wound to heal from is likely better. But yes, I would agree that the overall stress of surgery of being put on bypass and the inflammation that occurs with that is probably equally important in the frail patient. I think moving away to a catheter-based type technique in those really frail patients, as we've learned from the TAVR world, would be an indication of, or a signal perhaps, where less invasive surgery may provide better outcomes in frail older adult patients. It's less clear, for at least from the data that I've seen so far, that doing like a mini thoracotomy for mitral or other produces different outcomes in frail older adults. But intuitively, if there's less pain, they're able to move quicker, able to eat quicker, those are probably benefits for the older adult. Another one here, so I got that one covered. One from Munraj Sandhu, thank you for your question. Has PREA been published anywhere, and what are the key messages and outcomes? So we are working on publishing a randomized controlled trial where we did a multiple centered study. Unfortunately, recruitment was very slow because trying to get older adults to leave their home and go do something in a rehab facility preoperatively was a Herculean task that did not go as well as planned. We've retooled that for those two other studies that we referred to, where we're doing this as a home-based program for the exercise component at least, as well as the nutrition component. Particularly in this era now of the virtual world where we're doing a lot of things remotely, we're trying to develop virtual clinics for at-home consultation preoperatively to see if it works. With regards to the question on safety of a high-intensity program, we do have a baseline. They have to get at least 2 METs on a treadmill to deem that they're safe, plus based on their anatomy. We were pretty conservative with regards to left main disease or aortic valve area to minimize people doing activity beyond what may be safe, and really limited by symptoms in many cases. And then we try to tailor the actual program to the individual patient based on their capabilities.
Brilliant. When I had a similar question, patients who can't exercise, how do you advise them with regards to prehabilitation for various reasons, musculoskeletal reasons or other reasons they can't exercise?
Yeah, so those ones from a physical component are more challenging, obviously. And then for those ones, we'll likely try to prescribe some degree of nutrition advice and supplementation in the preoperative phase to target what we're able to target versus trying to do things that or provide opportunities that they're not physically capable of. I will say that particularly with COVID, we've had a shift to doing a lot more inpatients, and patients are waiting in hospital sometimes a week or more. We have developed an in-hospital walking program where we have a loop mapped out in our post-operative ward, and we have a little very simple low-tech biofeedback form where they mark how much they've walked on a given day. And we use that as a methodology to improve their walking whilst waiting for surgery in hospital. If they have difficulties with walking or require walking aids, we do prescribe then a physiotherapy technician to facilitate activity in those patients.
Thank you. Are there any more questions, Rakesh? Or?
I do not see any more at the present time, but thank you very much for the questions and those sticking out to the end of the day of a long 3-day meeting. I appreciate your interest.
Thank you very much for your excellent presentation. Shall we close the session?
I think so.
Okay, brilliant. Thank you so much, Rakesh.
Yeah, and thank you to all the presenters for their excellent presentation and to all the questions that have come through Slido. We did our best to keep up with all of them. We couldn't get to all of them in the interest of time, but hopefully that in the Slido app, our presenters can provide some responses to your queries. Thanks again for the opportunity to present and be part of the meeting.
Thank you, everybody, and thank you, everybody. Bye now.